you for the very thorough introduction. So I'm just going to give you a little background of what I'm going to talk about. So a lot of my research has focused on substance misuse. I've done a lot of work on marijuana, and a lot of what I'm working on now has been focusing on opioids, just given the scope of the problem and the impact that it's having in many communities. We've been doing a lot of work to focus on this. So I'm going to give a short overview of the opioid epidemic, talking generally about what's happening in the United States, also talking about families and what the impact of these issues on families are. And I'm going to be sharing some data today from a project. This is really fresh data. We actually just shut down data collection about 3 weeks ago. So we're still working to analyze it, but I'm really excited about this work. So as part of our evaluation for the state's targeted response to the opioid crisis, it was a grant that was funded by SAMHSA. We're doing some work to look at kind of the experiences of families. And our first step was just doing a survey with families who've been impacted by a loved one's opioid misuse. Okay, so can I just ask generally, how familiar are you guys with opioids and what they are? I know a number of you guys work on projects, so a lot of you guys are probably familiar, but just as a quick overview if you're not. So opioids are a class of drugs that include things like heroin, synthetic opioids, including fentanyl, as well as prescription pain relievers. So a lot of things like OxyContin, Vicodin, hydrocodone. And these are substances that reduce the intensity of pain signal perception. So the body will not actually, they're often used in treating pain. But some of the things that these substances do is that they activate the reward regions in the brain that cause that euphoria, that cause a high. And that's part of the reason we're seeing such the extent of the misuse of an addiction surrounding opioids. Another thing to point out about opioids that's important is that they can cause respiratory depression, so the slowing or the stopping of breathing. And that's particular concern, and where we see a lot of the overdoses occurring are related to some of those respiratory issues. And you may be familiar with naloxone, which is a medication that can be used to reverse opioid overdoses if it's administered right away. We've had a lot of efforts, including the state here in Michigan, trying to expand access to naloxone. And including a standing order, a lot of states have passed where you're able to easily get naloxone without a prescription. So in terms of what's happening on a daily basis with opioids, we're seeing over 500,000 opioids are prescribed, dispensed each day. And we're seeing every day about over 5,000 people are misusing opioids for the first time. And on average, we're seeing about 450 people each day using heroin for the first time. And when we look at the numbers in terms of the deaths related to opioids, they're quite staggering as well. About an average of about 130 people are dying from opioid overdoses each day. So when we look at the numbers from the National Survey on Drug Use and Health, it's pretty clear that the numbers, we have a very large problem that's grown worse over time. When you look at National Survey on Drug Use and Health data, there's about 11.1 million people who've misused prescription pain relievers, and just under a million that have used heroin in the past year. And when we've seen a dramatic increase in drug overdose deaths, and they've become a leading cause of injury death in the United States. So we're seeing significant increases in that area. Over 700,000 Americans have passed away since 1999, and the increases have been quite substantial. One thing I want to point out about kind of the trends with opioids is that we've seen some shifts in terms of the substances that are causing the opioid deaths. So when you look in the start here, back here, in 1999, we have the first wave of opioid overdose deaths. And those were largely attributed to the rise in prescription pain relievers. Starting around 2005, though, starting later, we started seeing a bigger shift and a rise in heroin deaths. So part of this, as we start becoming stricter with prescribing, we start seeing different shifts in what's happening and where the deaths are occurring. So more recently, starting in just around 2013, we've seen a very dramatic increase in deaths related to the synthetic opioids, so mainly fentanyl. And so we're seeing quite a bit of that happening. And again, opioids are accounting for about 2/3 of all drug overdose deaths. So when we look at the numbers for Michigan, one thing that really does stand out is that we've seen a pretty significant increase over time. So back again, starting in 1999, the numbers were quite a bit lower. Michigan at that point was lower than the national average in terms of opioid overdose deaths. And we've seen over time, though, the shift, and Michigan is actually now just above the national average. So things haven't gone so well in the state of Michigan. And as we've seen kind of use patterns kind of increase over time, there's some evidence, like in the 2018 date, the 17 and 18 data, that the numbers may have leveled off some. But we did see a significant increase in the number of deaths in 2017. So if you look, this map kind of shows you that Michigan is one of the states with the higher rates. So we're in that between 21 to 57 deaths per 100,000 in the population. So we are one of the higher rates, higher in the rankings in terms of the number of overdose deaths that we've experienced. In 2017, Michigan was ranked number 10, and that because of that, there's actually been a lot more of the funding from the federal government coming to Michigan to address some of these issues. One other thing too I want to point out about the overdose deaths and kind of looking at who are the people that are experiencing these problems. And when we look at kind of gender and just age, a couple things jump out. We have higher rates of opioid overdose deaths among men, which is kind of pretty consistent with a lot of typical patterns in substance use where we often see higher rates among men. But the largest number of drug overdose deaths are occurring among men ages 26 to 35 and then 46 to 55. So a little bit older than we see in some other substances. For women, the largest group of women that are experiencing overdose deaths tend to be a little bit older in that 46 to 55 age range. And one thing I want to point out is because of, these are the ages when these problems are occurring, many of these individuals are parents and have children that are still young. Okay, so as the problems in Michigan and throughout the United States have gotten worse, we've seen some shifts in efforts to try to address these issues. And one area we've seen a lot of work is trying to increase the availability of treatment. And there has been a very significant increase in publicly funded treatment available in the state of Michigan. Just looking at admissions data for heroin and prescription drug misuse, we've seen very dramatic increases. So back in 2001, just under 8,000 admissions for heroin. In 2016, we've had over 23,000 admissions. So there's definitely a lot of money and efforts in place to try to increase access to treatment. Similar with prescription opioid misuse treatment. Back in 2001, only 1,800 admissions related to prescription opioids. Now that number's over 9,000, which is an 8-fold increase in that short period of time. So that's one thing that's happening. And another thing that's really important to look at is also the expansion of medication-assisted treatment. So MAT just combines medications such as buprenorphine or methadone, also Vivitrol, some of the medications with kind of counseling, so things like CBT, other kind of counseling approaches. And it is evidence-based, it's an evidence-based strategy shown to be one of the more effective strategies to save lives and prevent overdoses. But it's been a challenge in Michigan as well as many other states in providing medication-assisted treatment for a number of reasons. When we look at data, Michigan, about half of the state treatment, half of those individuals that were in treatment for an opioid use disorder, they received medication-assisted treatment in 2016, and that's a considerable improvement from the past. But Michigan ranks 38th though in terms of the number of state-funded and the percentage of treatment facilities that are offering medication-assisted treatment. And one of the reasons we've seen some of the challenges related to this is that we have a limited number of physicians that have the waiver and are authorized to prescribe. We also see a good number of people that have the waiver but that are not actually doing the prescribing. So there's been definitely some issues related to the access of these treatments. And in particular in Michigan, we're seeing some challenges related to the geographics. So particularly in the Upper Peninsula, we have very few providers, much lower than when we look at the statewide average. So on average in Michigan, we have about 4.8 doctors per every 100,000 adults in our population. But geographically, some of the places that have some of the larger problems, like the Upper Peninsula or the northern regions of the Lower Peninsula, those are the areas that have very, very few providers of that. One other area that's gotten a lot of attention related to kind of families and opioids is opioid use during pregnancy. And opioid use during pregnancy can result in a drug withdrawal symptom in newborns called neonatal abstinence syndrome, also described as neonatal withdrawal syndrome. And some of the things to kind of keep in mind with this is that when children are born physically dependent on opioids, this often requires a NICU admission. It often requires a lengthy stay in the hospital. There's a lot of work that's kind of focused on some of the short-term consequences of neonatal abstinence syndrome. Some of the things that are commonly identified as short-term kind of challenges for these babies are issues like irritability, high-pitched crying, gastrointestinal issues, difficulty sleeping and feeding. So a lot of these problems. There's not been as much work, and it's not as clear in terms of the long-term consequences of exposure in utero to opioids. There's more work that's kind of looking at this, and it's becoming a little bit more clear. But there are some research kind of showing some challenges related to developmental challenges, attention and hyperactivity. I'm trying to think. But it is an area where there's not specific. There's kind of a growing body of work there. There's also some work that's kind of looked at in utero exposure and the potential for later substance misuse in those individuals as well. So when we look at kind of the trends though nationally, like what's happening with the opioid use during pregnancy, we have seen some increases in the incidence of neonatal abstinence syndrome and maternal opioid misuse. When we look at Michigan, for example, like back in 2000, we saw it in about 0.4 births per 1,000. It's gone up though, 2013, so it's a little bit old data at this point, but to an average of about 6.7 births per 1,000. So that it has been a pretty considerable increase, and you can see it nationally as well. So when we look at the rates, very low rates, kind of in the mid-2000s, and they've gone up over time. The other thing to kind of think about that, and there's been a lot of work from pediatrics where they're kind of focusing on just the growing hospital costs and for treating these issues. It's increased quite substantially over time. In terms of Michigan, We also see, again, those geographic differences where we're seeing high rates of neonatal abstinence syndrome in the Upper Peninsula. That region has some of the highest rates. In terms of the Lower Peninsula, these regions right here at the northern part of the Lower Peninsula, over here by the thumb, those communities have some of the higher rates as well. So it does vary when you look, across the state. And these are regions too, again, they don't have, they're, in terms of the population, they may be some of the less populated areas, but the rates at which they're experiencing these problems are quite high. So while there's been a lot of focus on kind of opioid misuse during pregnancy, another area that's gotten a lot of attention, particularly in the media, is opioid use and the impact on children. So we've seen some discussions about like the child welfare system. There's been some stories about that. And it's, parental substance misuse, I probably don't have to tell you, has been associated with poorer outcomes for children. There's a lot of evidence that shows there's a higher risk for neglect. And when you look at families that are involved in the child welfare system, we see substance use as a very prevalent problem. And it's also associated with a lot of more negative outcomes. So when you look at things like family reunification, time to permanency, we tend to see poorer outcomes when there is substance involvement in the family. One thing though I want to point out that's a challenge is that the data systems where we keep track of kind of substance use and in particular opioids are not very, very good in the child welfare system. A lot of our national data sets aren't able to connect the full extent of these problems. AFCAR's data, for example, this is administrative data states are required to enter about their child welfare systems. It's not a consistent screening practice from state to state in terms of how they're recording if substance involvement is in place, or is a factor in a case. We can tell from AFCAR's data that officially substance use is identified in about 1/3 of all child welfare cases. Other studies have said it's probably about 80% of youth in the foster care system have been affected by substance misuse in some way. We're seeing a lot of kind of focus too on the increases in foster care placements in the United States. And a lot of the anecdotal evidence has kind of attributed those to opioids. But again, it's difficult to kind of make a very clear connection with the data. And one other reason is that when we look at substance use data in child welfare, they don't identify specific substances. So it's really difficult to tease out, is it actually opioids or is it just substance use, and more generally other substances as well. And so that's one thing I think, as we continue to move forward, I think there's a greater recognition that we do need to kind of keep better data on these issues. So just to kind of give you an idea too, though, as I mentioned, a lot of the increase in foster care has been attributed to opioids. We did see a period of decline in terms of the numbers of youth that were in foster care following around the mid-2000s and downward here with fairly low rates around 2010. As the rates, though, in more recent years have kind of started to shift back up. And again, opioids are believed to be one of the factors causing this. There's a lot of anecdotal evidence. If you talk to people in the child welfare field, that's kind of the experience they're suggesting. But we're not really able to make that connection clear within the administrative data. When you look to, again, at AFCAR's data, the number of cases involving substance use, we're seeing an increase in that. So you're looking at new cases referred to the child welfare system. There has been an increase in the number of those cases that are involving parental substance misuse. And I'm not going to spend a lot of time on this, but I do a lot of work on adolescents and young adults, and it's an important group to talk about, particularly when we think about families. Just because young adults do tend to have fairly high rates of non-medical use of pain relievers. When we look at kind of the TEDS data, the treatment admission data, we see fairly high treatment needs among young adults. They're a group that tends to be overlooked in terms of not receiving treatment. And we're also seeing, when we look at that admission data, we're seeing younger ages of admission of individuals when they're seeking treatment for heroin and other opioids. So I think it does suggest we need to kind of also pay attention to that age group as well. So in terms of the response to the opioid crisis and what's happening, we've seen it become a national priority, and the government's focused on developing comprehensive strategies to address the opioid crisis. So some of the things that they've done, the Department of Health and Human Services has identified some of the priority areas that I've kind of mentioned already. So one of them I didn't talk too much about is opioid prescribing. So we've seen significant decreases in opioid prescribing. Some of you may have been experienced that as well. But the length of time for prescriptions now, we see much shorter periods of time. There's also been just a lot of work to reduce the number of opioid prescriptions. We've also seen a big expansion in access to naloxone. So as part of the state efforts, we've seen a lot of work just making sure like state police and different police units have naloxone. Also family members and individuals with opioid problems are encouraged to get naloxone. And we're seeing the other areas we're seeing big shift focus is the treatment, access to treatment, so including medication-assisted treatment. Also improving pain management, so moving away from opioids as our treatment for acute pain. That's one thing we're seeing, and we're also seeing an emphasis on research. So having better data and having a better sense of these problems can be really helpful as we're working to address some of these things. So as I mentioned, the federal government has been putting a lot of money towards addressing opioid misuse, and some of the grants they've done were the state targeted response grants. So every state and a number of territories in the US had gotten some funding. Michigan got $16 million in that round to do many of those things that I mentioned before. More recently, the latest grants that are coming out are the state opioid response grants, and Michigan's got requested about $27.5 million. So they're doing a lot with these grants, but one thing I want to point out is they're 2-year grants. Oftentimes they're going to get a year extension, so they're fairly short term. And just my experience as an evaluator on these projects is it's very challenging to do many of the things they want to do in short time periods, like training physicians to do better prescribing, or improving the access to treatment. If the grant only lasts a couple years, we can get an agency in the Upper Peninsula to hire someone that can prescribe medication-assisted treatment. But once the grant ends, that's going to be a lot of the challenge. So, so I think it's great. There's a lot of this work and a lot of money available, but again, it's an ongoing problem that's not going to be solved in just kind of 2-year increments. So what I'm going to focus on the rest of my time here is I want to talk about kind of the family members of individuals that have opioid use disorders. And for a number of reasons, I think this is important to look at this group. So we see, there's a growing number of Americans that have family and friends that have opioid use disorders. One of our surveys we recently did, it was just a public perception survey. We found, almost 70% reported that they knew someone who had an opioid, who had misused opioids. Other studies have shown, just under half of Americans report they've had a close family member or friend with a substance misuse problem. And so it's a growing problem, and in particular, I think it's also a very stressful problem, a stressful experience for family members. The unpredictability of addiction can be really challenging. We have participants talking about, I almost not knowing where their family members at, not knowing, what's happened to them. That can be a very difficult experience. Also, individuals, family members are exposed to a number of very difficult things. So they're exposed to their family member using drugs. They've witnessed overdoses in a number of cases. Sometimes they've witnessed the death of a relative. Another thing too that we see is when you start looking at affected family members, they also have high rates of things like depression, trauma symptoms, also substance use disorders themselves. So it's not just the individual who has the substance use disorder, their problem in isolation. It has an impact on their family members as well. And again, while we've seen, I think many studies though haven't really focused as much about family members, but they can play a really important role. And the attitudes and behaviors of family members can be particularly important in terms of engaging individuals in treatment, getting individuals into treatment. Having a family member that supports or encourages that can be really important. We also see in terms of when we look at like family relationships, having better family relationships, those tend to be associated with better outcomes. When you look at kind of more short-term and long-term recovery, we tend to see better outcomes when you have better, fewer relationship problems. Also, different communication styles within families have been associated with different outcomes. So having a more positive communication style can lead to better outcomes for the individuals that are in recovery. So while there's been some research, again, looking at the affected family members, I think it's a group, though, that we do really need to kind of increase our attention to. Some of the work that's been done so far, there's been a number of studies looking at training family members on how to use naloxone. So some of those efforts have been successful. There's a lot of the more general substance use research, too, that's also focused on affected family members. So we've seen some work in particular. There's a number of studies or interventions that focus on getting your loved one into treatment. How do you help support a loved one if they have a substance use problem? We've also seen some work on kind of the stigma associated with substance misuse in families. Cindy Wallace, she's I think a doctoral student in communication here at Wayne State. She's doing some work around that, for example. We've also seen some work on kind of families and what types of supports they're using. So are they using like online communities, programs like Al-Anon as well? So the aim of our work that we're doing is we wanted to focus on ways we might be able to improve the situation and the experiences of families that are experiencing opioid-related problems. So as part of this, with this kind of broad goal and overarching goal in mind, we recently did a survey of family members who have, individuals who have a family member who've misused opioids. So this data collection, it's just a brief online survey that we did. We were looking for a sample throughout Michigan, and recruitment, again, it just ended in February, so very recent. And it's not a random sample, very purposive approach to finding individuals. And we relied to a great extent on the state and their network of publicly funded treatment and prevention providers. We also relied to a large extent on Families Against Narcotics. And this is an organization that's started in Michigan and has expanded. There's also locations in North Carolina as well. But it's a group that's really been focusing on the experiences of family members who've been affected by opioids. We also did some kind of postings on some of the usual Facebook, Academica, and other social media. So in terms of our sample, our respondents were mostly women, not the most diverse. We had 299 people. In terms of the age, we did see a fairly large spread with that. So between the ages of 18 most of, I would say the largest two groups we saw in terms of the between 35 and older, the largest number of participants were from those groups. Just under half of our sample reported that they knew their family member had overdosed at least once. Most of our participants were actually unable to say for sure, though. They really didn't know. And we found just 44.7% of our sample had their loved one had died from an opioid overdose. So the difference there's not many that, many of those that are saying they knew their family member overdosed, it was because the person actually died. So So there's not great knowledge there.
So,
And
can I ask a question?
sure.
So the racial breakdown of the respondents, how does that compare to do you know what the general racial breakdown is among opioid users?
Well, I think a lot of the earlier data was with opioid misuse is that it was more of a white problem, so that it's fitting in that regard. We are seeing, though, increases as we've seen shifts in different substances. We are seeing different racial and ethnic groups seeing increases in the rates among those groups. So I would say it's probably it's not great, but it's not surprising, kind of, and I would say part of it is, I think, our recruitment strategy of using the state and kind of the fan networks. I think that was part of the reason we ended up with a sample, that's predominantly white, and I think it's something we should think about as we're kind of moving ahead and doing future efforts. Thank you. So in terms of the relationships individuals had, most of our participants, the largest group were siblings, so about 41%. Also 40% reported that it was their child that had misused opioids. Slightly smaller number, about 31% reported a parent, and 13% reported that it was a spouse. Now, one thing I do want to point out, though, is over 20% of these individuals had family members in multiple categories. We didn't do a great job, too, of tracking, like, did you have multiple siblings? Because that sometimes is the case. But we did ask how many family members that they had, and the average was 1.44 family members with a little bit of variance there as well. And some of the things that we asked participants about is what were some of their experiences as a result of their family's opioid misuse. And one area we talked about was kind of the financial burdens that people are experiencing. And we see quite high numbers of individuals that report they've had to take time off of work because of their loved ones' opioid use. We're seeing also fairly high numbers, though, looking at individuals that have had to borrow money, taking on debt from credit cards, other debt. We saw some participants, too, that are commenting that they've had to retire from work. We've also, not on this slide, we also found about 22% of individuals that went back to work after retiring, so it's impacting them that way. And a small portion, but 9%, remortgaged a home due to issues related to their loved one's opioid misuse. Now, in terms of the financial burden that's there, but we also see some additional kind of caregiving roles people are taking on. So about 18% of our sample reported taking on a caregiver role for children of a family member, and this included individuals that were taking on the children of a sibling, also grandparents caring for grandchildren, and we didn't see any differences based on age for that. We had only a small portion of respondents that reported they formally adopted a child that was a family member's. In terms of the family member's experience with naloxone, we did ask them about kind of if they've ever been trained on it, if they have or had access at their home, and we also did ask. We found a small proportion, just about 6% reported they've actually used naloxone on their family. In terms of supports, so it's a particular struggle for many of these individuals, and we wanted to find out kind of what types of supports they're using. So some of the things we talked about, we found is that a lot of them do rely on other family members, but they're also using other things, peer support. So the rates of use are particularly high, and again that may be due to our recruitment strategy where we used the fan networks. But we also see a lot of people utilizing kind of therapy for themselves, counseling for themselves, other folks that are kind of using online communities and online resources. We see a number of folks drawing on religious organizations as well.
Questions?
Sure.
Can you get support, say a difference in the type of support being used based on gender?
I haven't looked at it yet, but I think it would be worth looking at. The only thing I started looking at differences in treatment use based on stigma, so I'll kind of get to that in a minute, but I love suggestions like that of what we can look at. So as we collected data, one of the areas that I've often been interested in the work I do related to substance use is stigma. And again, stigma affects not only the individual that misuses a substance, but it also affects their family members. We have the term courtesy stigma, which is the stigma that close family members, relatives, or close associates experience because of their interactions with an individual who's been stigmatized. And so for this project, we actually adapted a measure of courtesy stigma that's been used in some of the research on caregivers of individuals with mental illnesses. And we included about 10 items on that. And some of these, just as some examples of things, like, you worried that people would find out about your family members' opioid use. You didn't see some of your friends as often as before. You felt ashamed or embarrassed about, and it would list your family members' opioid misuse. So we looked at some of those measures. One of the things that we found is we didn't see any differences in terms of the stigma experiences or reports based on demographics, so fairly similar rates across age, race, and education. We did see some differences, this is from a multivariate regression model, we did see some differences based on the relationship. So siblings reported lower levels of stigma than parents. Might not be too surprising. I think in our culture a lot, we tend to focus blame on parents a lot. And I think a lot of our parents in that sample might be internalizing that. The other thing too, we did see some other significant relationships with stigma, so higher levels of stigma. Those individuals also were more likely to be more critical of their relative. We had a measure of expressed emotion. Those individuals with higher levels of stigma also were more likely to use online supports. So again, if you're internalizing more of that stigma, you're going to be reaching out for in a way where it's less public. And there were also individuals that had higher levels of stigma. We also saw they had lower access to naloxone, which can be an important thing to think about how stigma might be affecting individuals. So just as a summary, it's pretty clear that opioid misuse exacts a very considerable toll on families. And our data just kind of hints at some of the emotional effects as well as the economic and financial burdens and some of the kind of caregiving for children that's been involved. And it also, this data kind of shows us that, small numbers of families have access in training use in naloxone. I would actually guess if you got a sample of affected family members who are not involved in groups like FAN, you might even see lower rates of access to naloxone. The other things too that I think are kind of important to think about is how stigma extends to family members and what the consequences of that may be. I think some of our data kind of is just hinting at that may be a particular challenge for parents who have a child that has an opioid use disorder. And again, stigma may further strain relationships with loved ones. We see that relationship with those with higher levels of stigma tended to be more critical of their loved one. The other thing, and I think that was important too, looking at how stigma might shape the services that family members use. Again, we saw a couple differences there with the access to naloxone and also use of online supports. So, a couple things I just want to kind of bring attention to as limitations and also think about as future work. The recruitment strategy has likely yielded this sample that's, it's biased in a number of ways. So again, this group is probably more likely to be engaged in formal support services, since a lot of them may have gotten the information from FAN. So that's one thing to kind of think about. But also thinking about just in future recruitment strategies, how do we get a sample that's more diverse from different parts of the state as well. And at this point where we're at in the project, we're actually developing an interview guide, and we're going to be following up with some of these participants And so some of the things that, you know, we're interested in looking at, and I would love other suggestions if you guys have them as well, but some of the things we're going to be talking to the individuals about are looking at kind of the feasibility and acceptability of supports or interventions that focus on or involve family members. Also, one of the challenges for many individuals is when you're trying to get treatment is just navigating the system. So talking to families a little bit more about kind of the challenges they experience as they're trying to navigate the system. How did they manage? What did they do? And then we'll also probably, you know, include some additional discussions about stigma and the impact it has on families. I think it's really important to kind of look at, you know, those folks that are reaching out, those people that are kind of getting involved in programs like FAN, but also families that are not talking about this. There's many, you know, families where they've lost a loved one or have a loved one with problems where they don't talk about this. They kind of talk about it as so-and-so's issues. It's kind of a, you know, a dark secret, and, you know, friends or family are too afraid to bring it up. So you see that as well. So I'm just going to wrap up here, but I just want to acknowledge that this work that we're doing, I think it's, you know, it's really important, and just in terms of the practical implications it has. And it's really been, you know, a number of people that are helping us to do this work. So many of my colleagues, Liz Aegis, Sue Brown, Victor, Jamie, many of these folks were working together from the School of Social Work. Jean Schoner from pharmacology has also been involved. And we have a great research staff. The evaluation work we're doing related to these state efforts, they're quite large projects. They're very messy. But I think there's definitely some important things that we can do in terms of, you know, improving the services in Michigan and working to try to address this issue. So I'm just going to stop and see if you guys have questions or suggestions or comments. Hey, Jennifer.
So this is wonderful. I have a kind of like how do we change the world question.
Great.
Yeah. So one thing I've noticed is that opioid use is seen as a crisis, as opposed to coke and the war on drugs that disproportionately impacts Black and brown and poor people. And when I was at the United Nations Commission on Narcotic Drugs and the Office of Drugs and Crime, it was similar. The dominant frame was war on drugs, no matter what. With some of us in minorities saying like human rights matter, you know.
Mm-hmm.
I'm wondering if you can speak to what has made this different. Or is it just that we've gotten better and this is the latest crisis? Or is it it's seen as a white person problem, which is then a more human problem? Or if it's prescription drugs, that indicates kind of class, and so it's richer people are having problems, or all of the above or other, like what is making this, our response to it be different? Imperfect, like you said with grants, but different than what I've seen in the past.
You definitely do see a difference in how, you know, we're addressing this issue, talking about it, how we're conceptualizing it as a problem. I think there are a number of things that you mentioned. So like one is just, for many people, to start with kind of prescription drugs. You see the, you know, some of the qualitative data, we see people talking about, well, they were on prescription pain relievers, and it's not as bad as heroin. They kind of, people in their mind kind of make this, they're almost like a better drug addict because there's a hierarchy in, you know, what your substance is because it was legal. So it's really, you know, it wasn't my fault. It was from my doctor, you know, that kind of thing. So we do see some things there, but there definitely, I think, are some problems in terms of how we've conceptualized kind of other substance use problems, thinking about like cocaine versus crack cocaine in the past and other substance use issues. And as we're seeing kind of the shifts, you know, a lot of the early opioid misuse and overdose deaths were white individuals, and we're seeing actually a decrease and an increase among a number of racial and ethnic minority groups. So I think it'll be interesting as we kind of moving ahead, see how the kind of issue is conceptualized. But it's something we need to really kind of be aware of and take into account, you know, when we're doing work in this area. So it's a great question.
Language that you're finding?
What's that?
Is there language that you're finding that's helpful?
And getting people who are like, no drugs, oh, but I'm on board with helping people with opioid misuse. Like language or arguments?
I don't know if I would say the big shift has been in kind of the substance use world has been focusing on person-centered language, which isn't exactly a response to what you're talking about, but just focusing on individuals and not just calling, we're not focusing on addicts and substance abusers anymore, the shifting to talk about individuals with substance use disorders, focusing on kind of the person itself. I would say that's one of the kind of shifts you've seen in the language more recently.
No, I'm just curious.
No, it's lots of great questions. I would love, lots of big questions.
Kind of related to that, do you have any plans either with this data or other data that you might collect in looking at stigma related to different cultural groups?
Yeah, I think, as we look to the future and collecting additional data, I think when we do our next round of quantitative data collection, I think we have to also broaden that recruitment strategy, so we can get kind of data on stigma from a number of different groups, because I think right now, it's a less racially diverse sample, so I think that would be something that would be very valuable. But we are going to be collecting more data, so we definitely have opportunities. One thing though we are trying to focus on too is when we're doing our qualitative follow-up, we have contact information for all these individuals. Many are very willing to be interviewed again and talk to us about their experiences, but we can also be purposeful as we're selecting what groups to look at. We do probably have enough of some of these different racial or ethnic groups to kind of try to recruit those individuals in larger numbers. Even just getting like 10 people in that group would probably be pretty useful. But we're also thinking about other subgroups within this data that we might want to look at as we're kind of doing the qualitative interviewing. And it's great. We do have a large team, so that I think that's one thing that as we do the qualitative work, we're able to get the data collected, transcribed fairly easily, just given the size of our team. And I think it's going to let us look at some of those different subgroups.
Just curious, in questions to the families about their family members' usage, are they asked how long they feel their family member has been using?
We did ask a number of questions about the family members' use, like how did they start, did they use IV drugs? A lot of that information they don't always have a good sense of. So they, sometimes, we have data that we had a couple open-ended questions where they kind of mentioned that I thought they were only using like marijuana and alcohol. I didn't realize until whatever, fairly late in that they were using heroin as well. So I don't think the families always have they may not always be very well informed of what their family member is doing, but I do find it interesting when we look at kind of how the family members, how they got involved or how they started, because we do kind of place a stigma in our culture, like why did you start using opioids? Was it you got your wisdom teeth out and you got a prescription and then it kind of spiraled from there? Because in our culture we tend to look at that individual much differently than someone else who may it started with illegal drugs, or they got involved in prostitution or something else. So it's interesting, I think, the kind of the cultural values that we have and how we think about these problems when we take that.
I was thinking in terms of family engagement or disengagement based on the length of time.
Yeah.
That the family
Well, and
member
it's one of these difficult things when you think about family members, the frustration and the stress that they experience. Often you don't know how to help the person. Oftentimes you feel like you have to kind of cut them off in order to not be codependent, not to encourage their behavior. So it's a challenge. It did jump out at me when I'm looking at the data though. Like we have smaller numbers who reported it's a spouse, and many of those in the comments it became clear they just divorced the spouse. So. But when it's a child, when it's your parent, when it's your child or your sibling, those relationships are long lasting. And so I think there's definitely work to be done to try to work with families You know, how do you deal with this experience? You don't want to enable the person. You don't want to kind of do things that are going to encourage the situation or make it worse, but at the same time, you know, it's your brother, it's your sister, your mom or dad, so it is difficult. Julie?
I think you kind of just started to touch on this, but how do you plan to use the findings? So is it, so like there already are a lot of support networks and support groups out there for families, so is it to help inform them about?
So part of it is, yeah, like there are a number of groups that are providing supports to families, but also, you know, can we expand the utilization of those types of services, figure out, get a better sense of how they could be more helpful to individuals. But there's also a good portion of people, again, that aren't reaching out, they're not talking publicly about their family's experiences, and just so thinking about ways we can also help those individuals as well. That's one thing that we're thinking about. But the other long-term goal is also, again, finding ways to increase the numbers of people that are getting treatment, and you know, improving kind of treatment outcomes, because families do have a very important role, just engaging, getting people into treatment, particularly if the individual is younger. Having families that encourage or buy into the idea of treatment can be important. But also, again, having those family relationships, they've often been strained over time with the, you know, substance use and addiction. So, but we know that if you have better family relationships, you're likely to have better outcomes with your treatment. So, you know, how do we find ways to kind of involve the families in the treatment process, or to have more positive relationships with the individuals when they're in that recovery process?
Question, if you have any thoughts on policy levels. You mentioned maybe NIH, but maybe not, but NIH definitely is more of a flashy, you know, fund what's flashy and trendy, and fund innovation. And then there's a whole of, we know this thing works at this community level for 5 years, but there's no funding to do it because now it's no longer new. I'm wondering if you have any thoughts of how to kind of change the government of your important points of like money's being thrown for 2 years, but then what do we do after those 2 years?
I think, I mean, there's I feel like the federal governments, they're throwing lots of money at these issues, so they can say we're doing a lot to address it. But again, thinking through these funding mechanisms, I think would be helpful, because, you know, this is a long-term problem, and when we have just very, you know, short-term grants, we're only making incremental changes. There's also a lot of bureaucratic issues, like, so the state of Michigan got all this money to buy naloxone, but then, you know, fairly far into the grant, the state police haven't actually bought any, and it's because they couldn't get the money from the other department. And so just bureaucratic issues that, you know, they shouldn't be such barriers, but, you know, they are in the reality. So I think it's important to really think about, you know, how we're addressing this. You know, many of the priorities I think are important in terms of, you know, focusing on prescribing, expanding treatment, improving the research as well. But again, you know, I think we need to think a little bit more long-term rather than these short-term efforts. They have focused the funding to the states that are experiencing the most overdoses. So Michigan has received quite a bit of the money because, you know, things have not been so well. We're seeing, you know, some shift in terms of the rates of overdose. We've seen a lot of shifts in terms of the prescribing. So things are getting better in some areas, but I do think we could do better in others. Well, thank you, everyone.